and shared with external audiences. Just please know that. And as you join, it would be great if folks could actually drop their title and their affiliation in the chat, so we can get an idea of who's joining us today. So please feel free to go ahead and drop that in. And I think we will start recording as well. All right. So my name is Elizabeth Cope. I am the Chief Programs and Science Officer at Academy Health, and I work together in partnership with Dr. Lucy Savitz, who is joining me in leading this meeting today. She's the professor at the University of Pittsburgh's Department of Health Policy and Management in the Graduate School of Public Health, and she's the Senior Innovation Advisor for the UPMC in their Center for High Value Healthcare. And past chair of Academy Health's board, which is my favorite part of the introduction. So we've partnered with AHRQ and the Scientific Resource Center, or as we lovingly call it, the SRC, to bring awareness to and help disseminate research findings of the ongoing evidence reports that are published by the EPC program. And so today, the reports that we will be highlighting focus on new research in workplace safety and well-being. We will have opportunities for open discussion and Q&A. That's always the best part anyway. I mean, I love the research. We love hearing about it, but it is fun to have the conversation where you get to engage with the content and really kind of dig in together. So when we get to that point, please feel free to use the hand raising and chat features throughout the meeting, and we will make sure that we capture that. So I think, yep, there we go. So this is going to be recorded, as I said, and at the conclusion of the webinar, we hope that those in attendance will have gained insight into the learning objectives listed here, or well, I guess they're, yeah, there they are. And at the end of the meeting, we will also share a link in the chat to an evaluation survey required for those interested. And so that was in that previous slide, is the continuing medical education credits. We do offer those. And so please take advantage of that at the end of the meeting if that is of interest to you. So today, what we want folks to be able to do at the end of this, we can go back, is to describe the key workplace conditions identified in recent safety and well-being reports that contribute to worker stress, burnout, and disengagement. We also are aiming to be able to explain how organizational policies, leadership practices, and job design influence employee safety, mental health, and overall well-being. So that would be beyond individual interventions. And then identify evidence-informed strategies and structural interventions that organizations and policymakers can use to improve workplace safety and support worker well-being. So that is what we are hoping folks will be able to do at the conclusion of this meeting today. So we can go to the next slide. There we go. And so here's our agenda. This is what we're doing. So this was your friendly welcome and review of the program. And then I will be turning it over in just a second to Lucy to provide some additional framing remarks and also introduce our authors that will be presenting today. And then we are going to hear, so what we have are those 3 presentations. So those are the 3 reports that are being discussed today. And then what you see in those initial reactions, we've got some invited folks here to provide some of their reactions to the reports to help connect it to some of our thinking around what this means for policy, for practice, and for community and patient perspectives as well. So those reactions will be shared. And then at the end, toward the end of the meeting, we will have some moderated discussion and Q&A. That's where we really want to hear from all of you. So we hope that you are thinking of your questions throughout, and we'll be able to bring those to that discussion. And then we'll also have some moderated discussion around policy and health system issues and sort of how we think about those in the context of the evidence being shared today. So that's what we're doing. And I'm going to turn it over to my colleague, Lucy, to provide some additional remarks and introduce our speakers.
Great. Thank you very much, Elizabeth. And thank you for joining us today. I'd like to just provide a little bit of a backdrop for the reports that we're discussing today. You may or may not be aware of the National Action Alliance to Advance Patient and Workforce Safety. This was an initiative of the Secretary of Health and Human Services. It was an initiative that was a public-private collaboration that broadly engaged people across the spectrum to inform us about advances that could possibly be made in patient and workforce safety. They generated 17 recommendations across 4 areas. And I think when you look at these reports, you'll see that they are looking at a variety of workplace settings that we would think about in healthcare delivery. So with that, I'm going to introduce the authors. So first, presenting today, we have Dr. Lee Jenkins, who's an associate professor of emergency medicine. He's the director of disaster fellowship and deputy director of the Johns Hopkins Office of Critical Event Preparedness and Response at the Johns Hopkins University School of Medicine. Next, we have Dr. Hassan Murad, a clinical epidemiologist and general preventive medicine specialist at the Mayo Clinic in Rochester, Minnesota, and the director of the Mayo Clinic Evidence-Based Practice Center. And lastly, the author presenting will be Dr. Michael Rosen, who's a professor in the Department of Anesthesiology and Critical Care Medicine at both the Johns Hopkins School of Medicine, as well as being principal faculty member at the Armstrong Institute for Patient Safety and Quality. He's the Associate Director of Team Science at the Institute of Clinical and Translational Research and co-directs the Applied Master of Science program, Patient Safety and Healthcare Quality at Johns Hopkins. And then joining us are 3 discussants who are going to help tease out a lot of the issues that we're discussing and seeing in these particular reports. I think you'll be really interested in hearing from them. Jade Perdue-Puli is the former director of the Division of Quality Improvement and Innovation Model Testing at CMS and is the current senior advisor to the director of the Center for Quality Improvement and Patient Safety, or CQIPS, at AHRQ. Next, we have Dr. Samruddhi Thaker, who has working experience from MITRE and RTI, as well as being a collaborative faculty member at the University of South Florida College of Nursing. And finally, Dr. Craig Umscheid, who's joining us as the former director of CQIPS at AHRQ and current Associate Chief Quality and Safety Officer at MedStar. So thank you all for being with us. I think this is going to be a great discussion. And with that, I'll turn it over to Lee to present with her report.
All right, thank you so much. So today we're going to be talking about our systematic review on mental health and occupational stress in emergency medical services and the 911 workforce. Okay, next slide. So the background on this, there's really been considerable mental health and occupational stress in the workforces of EMS. And when we say 911, we mean the telecommunicator forces. This is also known as our dispatchers. There's been a lot of both anecdotal and research done that shows that this has really worsened since the COVID-19 pandemic. The topic was nominated by AHRQ, by NHTSA to inform upcoming guidance. You may wonder why NHTSA. The Department for Emergency Medical Services, the head federal department, lives within NHTSA. And we did a large systematic review for this topic. Next slide. So our populations that we focused on was really the majority of the EMS workforce. This includes civilian, not military, field responders. They could either be on the ground or they could be a flight crew, and they could not be in training at the time of the study. So this includes paramedics, flight medics, critical care paramedics. It also includes other field personnel doing medical care at all different levels of training and education, EMTs, basics, intermediates. It also included physicians, nurses, and APPs, or advanced practice providers, that might be doing field response, physicians that are EMS medical directors, setting protocols, responding in the field. There was a lot of discussion, but we did end up including firefighters and rescue workers that do EMS, because a lot of these systems are combined systems and people do multiple roles. The telecommunicators are really our dispatchers, and we included all of them not in training. Next slide. Okay, so we're going to focus today on our key question 1, and that was, what are the incidence, prevalence, and severity of mental health issues such as depression, anxiety, PTSD, suicidality, and substance abuse, as well as other occupational stress issues like burnout, stress, and moral injury among EMS and telecommunicator workforces. Next slide. You can already tell just by our key question 1 that within our logic model, our number of outcomes is quite diverse. It is quite varied. And even our key question has many, many different components within behavioral health issues, kind of setting us up to talk about what are some challenges when we're studying in this area. Down below, you'll find our contextual factors that hopefully we'll be able to talk a little bit about, but we're not going to focus on. This was our kind of key question 3 within this study. All right, next slide. So our methods followed the usual AHRQ methods guide for effectiveness and comparative effectiveness reviews. We started off pulling studies from January 1st, 2001 through June 11th, 2024. We searched gray literature, we searched clinical trials registry, and then we even did journals not indexed in Medline. We did the usual risk of bias, evaluating strength of evidence using standard methods. Okay, next slide. All right, so getting into our results, again, we're mainly going to focus on key question 1, which had a total of 179 studies. Overall, we had 187 studies, but only 2 of these were randomized controlled trials. We had 6 cohort studies. The vast majority, 173, were cross-sectional studies. And more than 2/3 of the studies were published in 2018 or more recently. You can really see that as the pandemic started to happen, a lot of these studies became much more in number. Less than half of these were actually done in North America, United States or Canada. There is quite a bit of international work being done in this area. All right, next slide. So moving on to our very specific outcomes, let's talk first about depression. We had 67 studies on depression, and 8 of these were exclusively among telecommunicators. We had 58 on EMS clinicians, and then 1 study actually looked at both. So when looking at telecommunicators and EMS clinicians, they have varying levels of depression with a wide range and from mild to severe, both during routine practice and after critical events. To call out a couple of data points from below, you can see here that during routine practice, we had 7 studies for severity, and they showed mild to moderate symptoms with moderate strength of evidence. And then going down to depression and EMS clinicians, for severity, from minimal to mild symptoms, we had moderate strength of evidence for 16 studies, and quite a large number of participants, over 12,000. But again, looking at the range, and I know we're going to talk about this, the variation in prevalence is really, quite striking, anywhere from 0% to 53% reported in studies. All right, next slide. Okay, moving on to anxiety. We looked at 45 studies. The vast majority of these are in EMS clinicians. We only had 3 that were exclusively amongst telecommunicators. The prevalence and severity of anxiety among telecommunicators is really, quite unclear. Amongst pre-hospital EMS clinicians, anxiety levels were varied. They varied widely, ranging from mild to severe, both in routine practice and critical incidents. See, when we go down to look at EMS clinicians and prevalence during routine practice, we had 16 studies, and the variance could be anywhere from 2 to 70%. So that is quite a large range. All right, next slide. Okay. Post-traumatic stress disorder. We had 68 studies on PTSD. 12 of these studies exclusively enrolled telecommunicators, and then about 53 enrolled exclusively EMS clinicians. Again, the prevalence of PTSD in both varied quite widely, both during routine practice and after critical incidents. We're going to talk a lot about that. And then with very limited evidence for PTSD. You can look down on prevalence of PTSD in routine practice for EMS clinicians. That ranged for severe PTSD anywhere from 9% to 30%. Okay, next slide. Suicidality. So we had 13 studies that reported on the prevalence or severity of suicidality. Only one of these enrolled telecommunicators. So we really want to kind of call that out. And then you'll see we did have 10 studies reporting on the prevalence just during routine practice for EMS. And within that, you'll see that SI was 33%. So quite different than telecommunicators. All right, next slide. Okay. So on the prevalence of suicidal ideation among pre-hospital EMS clinicians during routine practice, you can see again down here that we have a 33% prevalence. But I do want to call again one data point on this slide. When you go to the sample size, the study here with the largest sample size, we don't even know the setting of this study. Was it pre-hospital? Was it urban? Was it rural? Was it interfacility transport? Was it critical care? So just kind of pointing out again, some of the challenges as we move to think about this data. All right, next slide. So on severity of suicidality, and this is based upon the suicidal behavior questionnaire among EMS clinicians during routine practice. You can see here that down at the bottom, the overall mean suicidality score is just to the left of 7. So that puts us at just under that at-risk line. All right, next slide. All right, so on substance use, we had 16 studies that reported data on the prevalence or severity of substance use. 13 of these, so the vast number, again, was on EMS clinicians. We had 2 studies just on telecommunicators. There is a moderate prevalence of alcohol abuse amongst telecommunicators during routine practice, but really insufficient evidence on alcohol consumption levels and abuse after critical events. Again, look at these small numbers. This is one study, right, on in prevalence on telecommunicators. So really difficult sometimes to kind of pull out strength of evidence from that. All right, next slide. All right, burnout. The outcome of burnout really was one of our most challenging. This was really one of the largest, most heterogeneous data sets that we had. We had 66 studies that reported data on the prevalence of burnout, 9 studies exclusively among telecommunicators, 54 amongst EMS clinicians. However, when you go down to prevalence of telecommunicators, we only had 1 study on prevalence, but we had 7 on the severity that showed mild to severe burnout. For EMS clinicians during routine practice, you can see we had 15 studies and with quite a varied response. High depersonalization was 13 to 99%. High emotional exhaustion was anywhere from 9 to 92%. So quite broad. All right, next slide. All right, so on stress. So we divided stress up into 3 different categories. I'm just watching the time. It's getting a little tight. We divided up stress into 3 categories. The first one is stress or general stress, job stress. The second is peritraumatic stress and secondary trauma. The third is post-traumatic stress or acute stress disorder and compassion fatigue. Next slide. Next slide, sorry. All right. So for stress in general, there really was insufficient evidence on stress prevalence among telecommunicators, really only 1 study, but we did identify high levels of stress after critical incidents. EMS clinicians also experienced significant stress, both during routine practice and after critical incidents. Next slide. Peritraumatic stress. We had 2 studies for telecommunicators during routine practice, and then again, no studies on prevalence in EMS clinicians. So you can see here that the data is really challenging. Next slide. Post-traumatic stress. We only had 1 study in telecommunicators during routine practice, and then we had 1 study on EMS clinicians during routine practice as well. Okay, next slide. Moral injury, we had 1 study that reported on the prevalence or severity of moral injury. Okay, next slide. All right, so we'll call out a couple of notable data points on these next couple of slides on the associations between modifying factors and all outcomes amongst telecommunicators. Let's just call out a trauma exposure. The red shows higher or more depression. So higher or more depression and PTSD in trauma exposure. And then we also had higher stress, peritraumatic stress and post-traumatic stress with a modifying factor of burnout. And then going down to staffing adequacy was a modifying factor for burnout and peritraumatic stress. All right, next slide. So associations between modifying factors and all outcomes amongst EMS service clinicians. Let's call out here paramedic. You can see that modifying factor. Actually, we see more burnout and stress amongst paramedics than the other type of roles. So that would be more than ambulance workers or more than people with a different certification. Paramedic is the highest level of licensure for EMS clinicians, usually working in the field. And then again, the modifying factor of trauma had more depression, anxiety, PTSD, SI, burnout, and other types of stress. The peer support access and use appear to be more protective against anxiety. And then for hours per week work, you can see here that had increased depression and PTSD and stress. Also, the urban setting was a modifying factor for increased SI and burnout. Okay, next slide. So what are our key findings? There is high rates of depression, SI, and alcohol abuse amongst telecommunicators during routine practice, significant variation in prevalence of depression, anxiety, PTSD, burnout, and stress. There were moderate levels of depression symptoms, stress, and burnout amongst telecommunicators, and mild to moderate levels of depression symptoms, anxiety, and stress amongst EMS clinicians. Moderate levels of moral injury amongst EMS clinicians. And we had no studies that actually reported on the incidence of mental health or occupational stress. We only had studies on prevalence. All right. And I think that wraps it up for the presentation of our results. Thank you.
Wonderful. Thank you so much for that presentation. That was excellent. I want to move to our reactors to provide some initial thoughts. So I think what I'll do for this one, I'm going to change it up as we go, but for this one, I think I'm going to go left to right with the names on the slides. So I'm going to go to Jade first. So if you want to kick us off with some of your just initial thoughts and reactions to the findings of this report, that'd be great.
Yeah, thank you so much. I just want to thank the authors for highlighting this important area within the healthcare delivery system. You know, from a policy and implementation perspective, my first thought was, gosh, we can do so much better when caring for our caregivers. And then my second thought was how important it is to find some immediate support and relief by looking at maybe some of the systems that have similar experiences. So that we might be better positioned to support our EMS and 911 operations staff. And certainly, as Dr. Savitz mentioned, through the National Action Alliance for Patient and Workforce Safety, which resulted out of the post-pandemic stress that we that our healthcare system experienced during the pandemic, the nursing profession has seen a lot of improvements in these areas, particularly over the past few years. We've observed how improvements in hospitals care for their staff, including things like providing peer support, having a focus on psychological safety in some cases, creating things like positive feedback loops where the healthcare staff, they're able to see the end results of their efforts, either through you know, a report or some specific feedback by patients or their managers. Scheduling dedicated time away, you know, even if it's doing another job temporarily. So it strikes me that there are some similar strategies that may produce some relief and similar results in this particular population. I think from a National Action Alliance perspective, I would love to reach out to NHTSA and learn a little bit more about what it is that they're doing and their bandwidth for rigorous evaluations and research in this particular area. So with that said, I will relinquish the rest of my time.
Thank you for those thoughtful comments. Let's move to Samruddhi.
Sure, thank you. And I echo what Jade shared. Thanks to the authors and the presentation today. So I think the additional perspective I want to bring to bear today is, you know, I found myself asking the question, what is it that I need to accept? One, as a citizen, you know, the other as a researcher, other as somebody who has had the privilege to advise policymakers, you know, as a patient advocate who has over the years, you know, last 30 years or so, especially last decade, I've had to interact with the 911 workforce, as this report mentions, as, you know, both the telecommunicators as well as the EMS staff that showed up on the scene. Kind of, what is it that I didn't know? What is it that I knew already that I must accept? And then what is then, if we are at a place where we have evidence to then, you know, essentially have either a call for action, whether it is, you know, more research or whether it is more research to implementation or implementation science that helps us improve how we care for this frontline workforce. So I found myself asking, a series of questions as I read the report. It also made me realize that clearly our 911 workforces, they are under significant amount of stress, and that's expected because they clearly are serving in a very, very critical role. People call the 911 when they need help. Time is of essence. Decisions have to be made by the 911 responders on the spot, uh, including keeping the person on the call while uh, the EMS workforce, the remaining focus of this report, they show up on the scene, may it be a home, a roadside, hospital setting, so on and so forth. So just overall understanding, for me, and while I appreciate the way, the science of a systematic review happens, it's, highly scientific and highly systematic, as it should be, and looking at specific outcomes. But I found myself also as a physician and a public health practitioner, wondering about, are there opportunities for us to do primary prevention? Are there opportunities for us to do secondary prevention? And most importantly, are there opportunities for us to look at these discrete outcomes that Lee presented, but rather than not look at them discretely, but look at them holistically from a patient-centered perspective. So whether it's depression, whether it's suicidal ideation, anxiety, PTSD, so on and so forth, burnout, can we look at it holistically? And can we then step back and say, how can we support the people who are choosing to work in these organizations, choosing to be the responders for us? When we call 911, we expect a certain level of performance, we expect a certain level of behaviors, we expect them to help us. So, if that workforce is suffering, even if it's 1 in 3 or 1 in 5 or 1 in 4, yes, there is variation, of course, but how can we support so that when any of us call 911, we can be assured that we will have a responder, and then responders coming to wherever we need help, essentially working at the top of the game. So, tied to kind of framing it in my mind that way, I was finding myself actually thinking about, if this is the current state of our 911 workforce, then what is the future state we can imagine, and how do we get there, and who can help us get there? So those were some of the observations, questions that came to my mind as I read the report, as I interacted with some of the additional information, but also just, in my various roles as a citizen, taxpayer, public health professional, physician, researcher, so on and so forth. So again, thank you for this very good work, and I look forward to further discussion. On to you, Craig.
Yeah, I very much appreciated the report. And for me, the biggest takeaway was just the shocking prevalence around suicidality for EMS clinicians. I think it was in the low 30%, and you had about 4 studies. It was reasonable levels of evidence. So that was a big takeaway for me. And even though we had limited evidence for 911 dispatchers, the suicidality in that group was high as well, I think around 12 or 13%. So really shocking numbers, and obviously needs to be addressed. I think the report also did help us understand some ways to address that. It showed that peer support was helpful. It suggested that fewer shifts, less mandatory overtime, less lengthy shifts were probably helpful. So it gave us some potential solutions as well.
Great, thank you. So a lot of reactions around sort of what we actually saw in the data, as well as folks sort of challenging us, right, to think critically about how we take, you know, when we have to in research sort of tease everything apart, right? Because you've got to like pull it apart to see what's going on and how things are working and all of that. But then what do we do when we have to put it back together and figure out what it means, right, for actual care, for practice, for policy, all of those things. So definitely things for us to be thinking about as we come back around at the end of our session. But now I would like to turn things over to Hassan to walk us through the report from his team.
Thank you and good afternoon again. Our report is about measuring documentation burden in healthcare. We can go to the next slide, please. I have no disclosures. We'll go next. As a background, we are all here today to talk about burnout and healthcare workforce. So this topic really fits in this context because satisfaction and burnout of healthcare professionals is something that has been recognized very well for the last 20 years. It's an urgent challenge that we believe is facing the healthcare system, and there's a lot of literature and studies about burnout. There are multiple contributors to burnout, but documentation burden is commonly cited as the main factor or one of the main factors. And this refers to the burden that is placed on healthcare professionals when they document their care, meaning they enter their notes, they order through an electronic health record, they receive messages, they reply to messages. So that's all is a burden, and that's what documentation burden is. So a lot of studies showing that burnout is associated with electronic health records. And now there may have been burnout before electronic health care records. So when we had paper records, but this wasn't really something that was prominent until the electronic documentation became standard. So it is, this burnout has been described in the literature to be associated with the electronic health records, with the computerized physician entry for orders, in-basket messages, and then patient portal. So this means messages that come from patients with requests, with forms, and other type of information. So all of this falls under the umbrella of burnout, of documentation burden as a contributor to burnout. Now, documentation burden in healthcare continues to increase. So there were studies that have looked at the last 20 years and have shown that this actually is increasing. So it's not a static or a stable burden. Next, please. So this project, this was done under the EPC program, under AHRQ. It was proposed by the American Medical Informatics Association. They had a task force that was focused on reducing documentation burnout by 25% by 2025. Now, 2025 has passed and the burden is still there. So I would view this endeavor as really an ongoing endeavor. As this is something that we will continue to strive towards. I don't think we can put a time limit on it, but it is something that is continuing and is increasing. The vision of this task force was that the U.S. healthcare workforce will be free of documentation burden and focused on patient care, improving patient outcomes, and doing what this workforce is supposed to do. The focus of this report, this project, was on the measurement of burden. So not interventions, focus on the measurement. Next, please. So the goals was to look at measures of documentation burden, look at their validity, strengths, and weaknesses. look at the perspectives on the appropriateness of these measures, and look at people in different roles. So look at healthcare workers in different roles, including patients and caregivers, trying to understand how the burden varies by different perspectives. Next, please. This was a technical brief, which is a type of systematic review that is a little different from the typical comparative effectiveness systematic reviews and meta-analysis. So in a technical brief, the topic is wide, it's of a wide scope, and the analysis is thematic, so it's not a quantitative analysis. The focus is not really on getting an estimate of effect, but rather on providing an overview of a large scope topic. We built on an existing framework by Moy and colleagues that was a result of a previous systematic review that looked at some of aspects of this work and tried to categorize burnout and describe it. So we built on this framework and expanded. We had 9 key informants. These are people that gave us feedback on our work. And they had different perspectives. They were healthcare professionals, including different types of physicians and a nurse. We had researchers, policymaker, and AHR trade association representative to kind of look at it, the issues that come from the side of the vendors and the developers of softwares. Next, please. All right, so the results. We worked through multiple databases. We had about 5,000 plus references, and we ended up with 135 articles. Next, please. So we identified 11 types of measures. Okay, again, to remind you, we're looking at measures of documentation burdens. Using a thematic analysis, we were able to put them in 11 categories or 11 types because that is how we can actually use them. So this categorization will serve into an application mode. So first is overall time spent in the electronic health record. So that's a very simple measure, which is time. So various studies looked at how much a healthcare provider will spend in the EHR, either as a time per day or a time per patient or a time per FTE of the provider and so forth. So simple time. The second type of measure was about activities related to documentation. So specific documentation tasks, such as the length of the documentation, the number of notes, the number of actions to complete a note, and the percent of time spent on documentation out of the whole time. So it was a little bit expanded compared with the first one, which was just pure time. The third type was about inbox management, so time spent on inbox management specifically, either time or number of messages. As you know, messages come to the inbox of providers carrying things like requests for refills, for prescriptions, requests for medical advice, questions, so all types of messages. Next, please. The fourth type was time spent in clinical review. So this is the provider is not documenting, but is reading documentation or synthesizing documentation. And this was also expressed as a time, pure time, or percent of time, percent out of an FTE, or percent out of a day, daytime. The fifth type was time spent in orders. So either time or number of orders, but this related specifically to ordering, placing an order for lab, for medication, for x-ray, things like that. The sixth type of measures was work outside of work. So the abbreviation, you may have seen abbreviation of WOW, WOW. So this is how much hours or time is the provider spending outside of their shift. So if someone works from 8 to 5, they could be spending an extra hour from 5 to 6, for example, on the EHR. That's a common measure, and that you can clearly see and intuitively how that can actually contribute to burnout. Next was the seventh type was administrative tasks. So activities such as billing, filling forms, and these were also either presented as a time or a proportion of time or count. But these are things that are not really patient care. This was more like I mentioned for billing and forms and things like that. Next, the eighth type of measures was actually about fragmentation of workflow. So things like task switching, interruptive alerts, or documentation while you're doing other activities. So a lot of things that can come under multitasking. So you could be documenting in a note when you get an inbox message and you have to switch to it, or you get some other type of interruption. So this we call fragmentation of workflow, and that actually has been a measure that's been studied in various types of studies and associated with burnout, and also described as a measure of documentation burden. Number 9 is measures of efficiency. So for example, percent of closed encounters. So if you're not familiar, but a healthcare provider will have multiple encounters during the day. So every patient they see will have an encounter. They need to document in it, put orders, bill, finish it, and close it. So, but people don't close them in time. So at the end of the day, you may have 50% closed or 40% or whatever. So that was a measure of documentation burden, is how many encounters were closed, how many messages the provider responded to, how many test results were acknowledged and acted upon, and so forth. Number 10, the 10th type of measures was an activity rate. So number of actions such as clicks. So how many clicks, a mouse clicks, how many keystrokes, how many miles or pixels per minute of a mouse movement, how many logins per shift. So these are small tasks that all relate to interaction with the electronic medical record and can be a surrogate for documentation burden. And lastly, the last category is a wider category that relates to the usability of electronic health records. So there are specific usability scales. There are scales for satisfaction with electronic health records, surveys about ease of documentations, the concept of techno stress, so stress related to EHR. So this is an umbrella of different measures that all relate to the electronic health records and how the user view it as difficult or easy. A lot of the studies showed actually the poor usability and a lot of techno stress with the EHR. Next. So these were the measures. These are the types of measures, these 11 types. In terms of applicability of these measures, we thought that they were very applicable because they had very diverse settings. So the studies that looked at these measures were in ambulatory inpatient settings, rural, urban, surgical, medical, academic, community. So they were in a variety of conditions that really are consistent with the current practice. Next, please. So the source of data that came into the measures, the most common one was the EHR usage logs. So this is the EHR itself will log these measures and generate reports for the user. That was the most common one. There were some studies that looked at self-reports, so the providers will get a survey and will answer, for example, how much time they spent in an EHR. And then there was what's called direct tracking and time motion analysis. This is when you have actually formal analysis of taping people, and it's a specific type of study that is very comprehensive and detailed, but these were not very common. Next, please. For validity of these measures, so we adapted a model by MESIC that looks at 5 sources of evidence that support construct validity. So the first type of evidence was content. So does the content of the measure capture the construct? So for example, in documentation burden, simple time measurement, we consider that to not really satisfy content validity, because time is just a simple component, like one component of this large burden. The burden has other domains beside time, such as multitasking, for example, and fragmentation of work. So that's how we judge the content validity. In terms of response process, so are the actions and thoughts of the researchers and respondent in the studies that intended to measure the burden, were they really consistent with the burden? In other words, when they were evaluated, did they know that the purpose of their survey or their study was to actually look at burden? Next, please. The third type of validity evidence was about the internal structure of these measures, such as reliability and reproducibility. So if you think about the logs that capture time from EHR, these are very reliable and very reproducible. So from that aspect, they will have high validity, but as I mentioned earlier, they may not have content validity. Another type of validity evidence, number 4, is relation to other variables. So if these measures correlated with stress, for example, then that will give them additional source of validity. And lastly, the 5th type of evidence is consequences. So was the documentation time associated with burnout, for example, or patients' outcomes, or the quality of teaching that residents and medical students get? As if there were consequences, that will give more validity to the measures. Next, please. So this is the results of all these 5 types of validity evidence. You can see that maybe all of them are below 30%. So these are the percentages of the studies that satisfied every type of validity evidence. Most of them were less than 30%, meaning they were probably not as valid, but somewhat valid. Next, please. So the perceptions of documentation burden were mostly from physicians, then followed by nurses. So the studies were, I mean, if you look at physician nurses, probably 95% of the studies really address these 2 types of healthcare providers. It was mostly in the US, with a big focus on burnout and stress and satisfaction of physicians with the EHR, which was in general poor. There was some trainee perspective. Trainee means medical students, residents, fellows, and their perspective was that the more time spent on EHR, the less time was spent on teaching. Next, please. The role of the patient was in general viewed as a contributor to the burden. So the patient increased the burden by in-basket messages and asking for forms and refills and so forth, which is, I think, is expected. But this was underexplored really, and there was a lot of uncertainties in it, and that topic by itself needs to be studied extensively more. This is a very kind of high-level view of it. Next, please. These are mediators that were identified in the studies. I'm not going to go into a lot of details in them, but there was providers level ones, practice level ones, and then other factors. So these are things that will change how these measures would work. They're mediators, so they will change the way those measures will be accurate or valid. Next, please. So in conclusions, there are numerous measures of documentation burden. They are highly applicable. They have looked at a variety of practice settings. We categorize them into 11 types. But most were unidimensional, so they didn't look at all possible aspects of the burden. And they were focused on time for the most part. The fundamental instrument development procedures are needed. So as I showed that the validity was maybe about 30% of the studies had reasonable validity. And I think this technical brief should serve as a call to action for intervention. I think measuring is the first step, but really the goal of measuring is to intervene. Next, please. I think that was it. Acknowledgement to our report authors, key informants, and of course, from AHRQ, a lot of work was done by the AHRQ task order officer, who are Dr. Carr and Dyer. Thank you very much.
Thank you. That was excellent. I'm just noticing sort of like a time check that we're running just a little bit long. So I'm going to ask our reactors to keep their remarks a little bit tight. But so I think this time I'm going to go ahead and start with Samruddhi.
Sure, thank you. This surely was a topic, all of them are, but this one especially, a major documentation topic dear and near to my heart. I come with several perspectives. Some of them I mentioned before. One of the observation that I have, and in the interest of time, I will limit it to one or two right now. So one was I found the patient and caregiver perspective, which is what I hope to bring up later in the discussion, missing in terms of the key informant. And again, as I saw the studies, that perspective seemed to be less captured. And I will tie that one to what Hassan, you mentioned about, what's emerging from the technical brief you and the colleagues wrote is seeing the patient correspondence as documentation burden. So those are two observations in the interest of time I want to mention here, that when a healthcare system or healthcare delivery system starts experiencing the kind of burden we are experiencing because of documentation, that might be resulting in us starting to see the patient as a source of burden. I mean, none of us will exist if we didn't have patients to serve. So I just want to leave it there in terms of just an observation as I read. And again, something I would love to explore further in terms of discussion. Back to you. Thank you.
Great, thank you. Let's go to Craig.
Yeah, thanks, Hassan, and thanks to you and your team. I felt the same way, that I had a lot of interest in this report. I think a lot of us as clinicians do. I have to admit, at one level, I was surprised that there wasn't, one or two or three all-encompassing measures of the burdens that clinicians go through in documenting in the electronic health record. I thought there may be just one or two that were more common across studies. That said, I shouldn't be surprised, because there are a lot of tasks that we attempt to accomplish in the EHR, from admitting patients to caring for patients, discharging patients, writing orders, billing, getting clinical decision support, all of these things that you talked about. And that's just from the inpatient physician perspective. So we do expect a lot from our electronic health records. I was very happy about the framework that you developed, these 11 categories of measures. I found that to be very helpful to review. I commonly think of the last two measures that you highlighted as, maybe more actionable measures of documentation burden. I think one was around EHR activity and one was around EHR usability. And with the advent of AI, it got me thinking about whether AI may be a tool that could be used in the future and applied to the logs in the back end of the EHR to help us understand how challenging it is for clinicians to interact with some EHRs versus others, and produce a more common measure that could be scaled across all the EHRs. But congrats on this work.
Thank you.
Yeah, I'll just follow Craig and chime in. Thank you so much for shining a bright light on this. It is really super important. And where my head goes is, of course, policy and implementation. And measurement is critical here. You know, I think we all know what burnout is when we see it and certainly when we experience this, but how do we know that the changes that we're making are resulting in improvement? So, so thanks again. I was thinking, gosh, who should take the lead on, you know, standardizing burden reduction measures and how complex it is and the different areas within healthcare delivery that burden rears its head. And so there are really so many important players to ensure at the table. Most certainly could be led by a federal agency like AHRQ or CMS, but I really love the thought of partnering with vendors in particular to identify areas that are ripe for standardization across systems and measurement, that even with very modest changes would improve clinician experience and reduce burnout. And when I say clinician, I mean all clinicians, and not think of this as something that has to be siloed for one clinician for another. So really, really nice. Well done. Thank you.
Thank you.
Great. Thank you for those thoughtful comments. Appreciate it, and appreciate the attention to time as well. You're doing great. All right, so let's transition to our last but not least presenter. So Mike, I'm going to turn it over to you.
Thank you. Good afternoon, everyone. My name is Mike Rosen, and I'll be talking today about a report we did on the issue here around fatigue and sleepiness of clinicians due to hours of service. And this was a rapid response review, which was part of the AHRQ's Making Healthcare Safer For collection of reports. And our team is here, myself, Molly Cullen, Alan Jang, Ritu Sharma, Christopher Zhao, and Eric Bass from the Johns Hopkins Evidence-Based Practice Center. And of course, the full report is there and a paper detailing some of this as well. Next slide, please. So here are our research questions, or our key questions, and there were 8, which is a lot for a rapid response, but these were commonly structured questions across all of the Making Healthcare Safer reports. But the core issue we're focusing on here is, we all know as human beings, it's a fundamental thing. If we have not enough sleep or sleep disturbances, that leads to cognitively impaired functioning in terms of memory, attention, decision-making, just general human performance gets worse under a state of fatigue, and those absolutely can translate into errors, mistakes, lapses, which in turn can translate into patient harm. But the goal of this was to understand the frequency and severity of harms associated with fatigue and sleepiness due to hours of service, what patient safety measures or indicators have been used to examine that association. And then 3 and 4 are really about understanding the patient safety practices, the PSPs, the interventions, the approaches to mitigating or preventing that risk that are used, and then what's the rationale. And then 5 is about understanding their effectiveness and any observed unintended effects of those patient safety practices. And 6, 7, and 8 are really about implementation. I'm not going to talk about those during this talk, but really we found very little information about this. Next slide, please. So this, again, as I mentioned, this is a rapid response review, which means it's an abbreviated review focused on identifying research. There's less emphasis on integrating or evaluating study quality, things like that. So we were focused on being as specific as possible with our research questions within the context of this broader report effort, limiting the databases we searched, modifying our search strategies as much as possible to be as sensitive and specific as we could, and the eligibility on the right-hand side here, which was we focused just on literature since 2013. This was an update to a previous Making Healthcare Safer report, which ended its search in 2013. So that's where we started. All studies were in the US, only in acute care hospital settings, and all studies had to include some comparator and an outcome of interest, which, as we go through the results, we grouped into kind of clinical outcomes, which were things like mortality, morbidity, complications, length of stay, readmissions, and safety outcomes, which were either self-reported or otherwise detected errors or adverse events. We did include systematic reviews, randomized and non-randomized trials, of which we did find several, and observational studies with a comparison group. Next slide, please. So this is our jumping right to our results with the time, and I'll preface all of this by it is a complicated literature and it's difficult to pull clear conclusions from, but we'll walk through kind of what we found, and there are some clear themes of what's going on here. So we found ultimately 12 systematic reviews and 20 primary studies across 21 different articles for inclusion criteria. And there's a plot of the original studies, and you can see there were 5 randomized controlled trials. These were exclusively with residents as their subjects, medical residents, trainees, either surgical internal medicine residents or pediatric residents rotating through a pediatric intensive care unit. So those were the larger, higher quality studies, even though we did not do formal quality grading for the studies. Those are the bigger ones, and that's a very unique population for these types of challenges. Next slide, please. So in terms of our key questions 1 and 2, which were really about the prevalence of safety harms related to fatigue and sleepiness due to work hours, there's certainly evidence that healthcare workers have sleep deficits. So these were in surveys, and we know fundamentally that human beings function in an impaired state when they don't have enough sleep, or that sleep is disrupted. So a CDC study found about a little over a third of healthcare clinicians and technical workers reported short sleep durations in 2018, which was a 15% increase over the preceding 8 years prior when that was done. There was a meta-analysis of studies looking at sleep disturbances during the COVID pandemic, and anywhere between a third and a little over 40% of physicians experienced sleep disturbances during that time. And when we look at the overall amount of hours, which is one of the key things we look at in this work, 17% of healthcare workers work 48 hours or more a week, 6% work 60 or more hours per week. And then, of course, there's over 100,000 residents who work 80 hours per week, including shifts of up to and over 24 hours in duration. So there's fair evidence that there are sleep challenges, certainly in this industry. The existing literature has looked at a wide variety of outcomes, including medication safety, a variety of surgical outcomes, patient injuries, generalized errors that happen, much of it self-report, but not all self-report, mortality, morbidity, readmissions, infections, and length of stay have all been kind of examined in this literature. Next slide, please. So the interventions we found, so questions 3 and 4 deal with the patient safety practices people are implementing to mitigate or eliminate these risks, and 4 is the rationale people are providing. Overwhelmingly, this literature has looked at the total amount of hours worked over a period of time, whether that's shifts, weeks, months, typically, or the structure of those shifts. So these, for those, obviously the total amount of time someone works, the rationale is you can minimize the cognitive and physical performance decrements that people see, that you see when people are working in a fatigued state. The structural component of the shift has to do with maximizing recovery time between shifts or minimizing circadian rhythm disruptions, which is also can impede people's ability to recover and contribute to their fatigue state. So that, in addition to that, a kind of a specific version of that are the ACGME duty hour regulations. And briefly, there's 3 sets of large ones. 2003 limited the overall work week to no more than 80 hours, and as well as some restrictions on the individual shift duration, which was no more than 30 hours. Then in 2011, there were some additional constraints put there, which further reduced the maximum shift duration for first-year residents to 16 hours and 24 hours, no more than 24 hours after that, and also had many stipulations over recovery time, the minimum amount of recovery time required, and it was an administratively burdensome set of regulations to adhere to. So for various reasons, including that, there was some pushback from different programs, and in 2017, there was a little bit of easing of some of those restrictions, specifically around first-year residents. They could then, in 2011, were restricted to 16-hour shifts. They could then work for 24-hour shifts. So again, most of our larger scale studies and randomized controlled trials we found were around variations of that shift structure. And then we were hoping to find, but did not find much more, were things in addition to the shift structure or total hours worked. Things around workload, who has heard is incredibly important. Not all hours worked are the same and have the same impact on people's fatigue state. So what can we do about workload, but also environmental conditions play a big role in people's level of fatigue as well, including lighting, noise, and other types of things. And there's a collection of fatigue risk management practices across industries, and we are looking or hoping to find some of those evaluated. Next slide, please. So go quickly through the results we found, and again, it's a complicated literature, and there are a few very clear takeaways from this, for many reasons, because residents have been the focus too. So we found 12 systematic reviews, 20 primary studies, and 21 different articles. And most of that was focused on shift structure or total hours worked, and very few studies on risk management practices. Next slide, please. So for the clinical outcomes, we looked at, again, there was mixed evidence in the systematic reviews around resident duty hour limitations, in the shift duration or night floats on mortality or length of stay. For nurses, there was an association between increased overtime and insufficient time between shifts, and that was associated with patient mortality in 2 different reviews. For primary studies, again, these were primarily the RCTs for residents. There was conflicting results and findings in some of these studies. For the surgical, I'll spend a little bit more time on these 2 studies. For the study conducted with surgical residents, the manipulation was standard duty hours, which limited to 24-hour maximum shift duration, or what they called a flexible, which was a waiver from ACGME to let residents self-select to work up to 30 hours. And the argument for doing that was it reduced transitions of care and handoffs, and that would improve safety. It was structured as a non-inferiority trial, and the 2 arms were equivalent essentially. So that didn't help people make decisions, right? So if people thought that in general you shouldn't be forcing people to work that long, they took that evidence that was what we should be doing, because you did not see increased safety risks because of reduced transitions of care. And people who wanted the flexibility to let people work up to 30 hours took it as evidence. Is that what we should do? So that didn't help really resolve any of those decisions. And there were some challenges with one of the other studies in the pediatric residents where they compared a reduced quick rotating schedule of 16 hours to the longer 24 plus hour schedule, and in two different analyses found two different things. But in the first one, they didn't account for workload, and when you account for the workload people are under, working the reduced schedules did show benefit for safety outcomes. Next slide, please. Sorry, this header is mislabeled. This is for safety outcomes. And here, the systematic reviews did find that extended duration shifts were weakly associated with serious medical errors, but that was not always the case across all of these. However, for the primary studies that were included, there was fairly consistent evidence that the work shift modifications, reduced hours, were associated with reduced medical errors and near misses. But again, most of this was self-report data, other than one done with nursing shift. They looked at errors generated from the medication dispensing system and roster hours for nurses, and did find that nurses working longer hours, greater than 13 hours, had lower, they had more frequent errors in the medication administration system. Next slide, please. So for risk management practices, we did not find much, but what we did find were some ergonomic interventions around lighting, ambient lighting in the workplace. For radiologists, help decrease detection and identification errors, and instituting for nursing, instituting protected time for brief naps during extended shifts did help. So they had breaks for naps protected up to 2 to 4 hours, and that did result in less missed nursing care for patients. But a review did have a different take on nursing breaks. So the literature there is a bit mixed as well. Next slide, please. So I think the limitations of this review is we didn't have a lot of time to dig through the details and integrate as much as we like. We found a lot of interesting stuff telling very different stories about what's going on. There's way too much emphasis in this literature on residents. They're clearly an important population in an extreme case of work hours, compounded by the fact that they're learning. So this is harder work for them than an experienced clinician. But that doesn't tell us, it tells us very little about everyone else. There are not a lot of things besides hours worked and shift schedule in here, and there's a lot of heterogeneity in the outcomes and the methods, a lot of inconsistent terminology, and even how they're describing these shifts and putting them together. It's very difficult to understand what they're actually doing and what that means. And a lot of observational research, very few RCTs, none that we found outside of resident population. Next slide, please. So, unfortunately, I don't have a strong takeaway from the evidence of how much is too much, or in terms of work hours, or clear guidance on how shifts should be structured. We know healthcare is provided by human beings. Human beings have limits in capabilities. The 24/7 operations of a healthcare system mean that those people are going to be stretched to some extent. I think there's a lot more to do with understanding what is going to be most effective, balancing the needs for how we put these schedules together and run them. And certainly there's a lot more to learn about what we can take from the broader fatigue risk management world and apply that in our context and make that work for us. So I think that's the end. Hopefully I didn't go too long. Sorry.
You're doing great.
Okay.
Everybody's doing great. All right. Thank you very much for an excellent presentation. I am going to turn things over to our reactors, and we'll start with Craig this time.
Yeah, thanks, Mike, and to your team for that summary. That was a lot of work for a pretty limited type of systematic review that AHRQ supports. So congratulations, a lot of findings there. I have to be honest, I wasn't overly surprised about the mixed findings. Ideally, we'd be looking at studies that compare residents who are working longer hours and have less sleep to those who are working shorter hours and have more sleep, and everything else is held constant. But that's obviously not what these studies are comparing. I mean, most of the studies, like you said, are looking at different models of care. One where maybe there are longer hours, but maybe there's less workload intensity and more continuity of care versus shorter hours, but maybe a lot more workload intensity and a lot less continuity of care. So it's really tough to understand the balance of trade-offs there. I also wasn't surprised that most of this work was done in house staff or residents. I mean, they're reasonably inexpensive labor that are used particularly across inpatient settings all across the US. They're the providers who, for the most part, are working, 80, 90, 100 hours a week. And so, they're clearly at the most risk of having fatigue impact patient care. So those are my initial reactions. Thanks for that comprehensive but brief report.
Great, thank you. Let's go to Jade.
Yeah, thank you. Well, I wasn't surprised so much by the findings, but I really appreciated your statement about the complexity of the review. And it occurred to me that really speaks to the complexity of the healthcare delivery system. And as I was thinking about, again, policy and implementation, I was thinking about the many different key levers that this focuses on, and that includes things like leadership, safety culture within an organization, at a systems level, capacity building, just to name like three of the big ones. The thing that I was surprised about is that the lack of toolkits that you mentioned. So that, of course, makes my ears perk up. I think this feels really ripe for something like a best practices review, just to begin a national conversation in this area or reignite the national conversation. I know it's been going on for some time, but it feels like something that we can get our hands around. Taking into account the differences, of course, that we see between rural and urban and specialty care and that sort of thing. But yeah, those are my initial thoughts. So thank you.
Thanks, Jade. Let's go to Samruddhi.
Thank you. I couldn't agree more with Craig and Jade, and thank you for the excellent rapid response report. I'll like to add, just from my standpoint, couple observations, and we can hopefully build on this if time permits in the discussion. So one thing that made me pause a lot is just what I call the intractability of this particular issue. And I'm going to call it issue as opposed to a risk, because I think this has been a topic, as some of us already know and we have mentioned, for give or take 30 or 50 years, especially specific to resident physicians. So just the fact that it's so intractable, to me, makes it very important, exciting, and hence this rapid response, can turn to call for action. And I hear you, Jade, in terms of not having any toolkit. I mean, surely that identifies a gap, but nonetheless, that's one observation I have. The other is, I couldn't help myself wonder, healthcare delivery is a knowledge driven sector, and the fact that we still in 21st century 2026 expect a knowledge driven sector have workforce, not all, some work up to 80 hours or more, and actually make decisions in real time and make sound decisions, make decisions that actually inform patients, sometimes life and death, oftentimes, decisions that can prevent, hopefully more suffering. So just the fact that it's a knowledge sector where we expect individuals to work so much. And again, I know this, report didn't find all, I get that. But even the fact that we still expect resident physicians, and as Craig said, it's the workforce for the hospitals, and that's in some ways the cheapest. The other observation I have is I was trying to find out, in terms of the funding for especially graduate medical education, it's, from what I could tell, give or take 25 to 30 billion. Most of it comes from Medicare. And if I think about it from, just the fact that there is this amount of investment to develop the workforce of the current and the future, and in some ways I find, the question is, could we dedicate this amount of monies to train this workforce, especially the physicians, but all of healthcare professionals, better, so that, and it ties to what I, fumbled into while I was trying to make sense of the findings of this particular rapid response. So I saw that AHRQ is going to have a conference end of February, and I saw the title is Meaning in Medicine, and they have efforts about joy and meaning in medicine, back to bedside, and it all kind of, I call it, almost came together. The reason we need efforts where we talk about meaning in medicine, where we talk about joy and meaning in medicine, or back to bedside, is because in some ways, when some individuals are having to work such long hours, and it's almost by design, the AHRQ requirements. I mean, it makes me wonder, is it a kind of some of the interventions that you identified in the report, or is it more of stepping back and not thinking of, just the lighting or just this or just that, but actually tying it to the second report, which is, documentation burden, because some of the time actually is going in that. And of course, some of the discussion from the first report, which also emerges here, which is, the burnout, the, kind of burden that when somebody works so much, experiences fatigue and sleepiness. And, is it setting us up for a workforce that's not working at the top of their license? Kind of, if that's the case, then it's going to affect the kind of services we deliver, the kind of conversations we have with our patients, and ultimately would affect the kind of help we can provide to the patients that are coming to us. Because ultimately patients come to us for a reason. Hopefully they want to get well. And our ability as a healthcare system to meet their needs, to assess them, all of that gets eroded if we are not working at the top of our license because of the number of hours, or because we don't have the adequate support, so on and so forth. So I'll stop there and look forward to the discussion ahead. Thank you.
Wonderful. Thank you very much. All right, so there's much to discuss here. And so that brings us to the end of the part of the program that is dedicated to each individual report. And so I want to thank all of our presenters. We now have some, we're gonna pivot and turn to questions for the authors. I do want to open the floor to folks that are participating. Please use the chat to let us know if you have questions, and we are happy to turn over to you all. I will say I see that we did get one question in the chat. I believe it is for the first report. And this is from Donald Leiter, and his question is, how is time in the medical record measured? Is it keystrokes? Is it login time? How is that done? And so I think that that question is directed to Lee.
I think that's directed to me.
Okay, let's
Yeah.
try that. Sorry.
Yeah. So time in the medical record is measured is either in time as time unit or as a percent of time, or it's measured in as specific activities. So specific time in basket, time in orders, time in review, so reading. So yeah, so it's either measured as overall or measured as specific activities. And then of course there are the other measures that we discussed, such as keystrokes and all the other measures.
All right, great, thank you. So while we kind of wait for additional questions to come through, I think I can kick things off a little bit, and so just want to ask a few questions here. So I'll start with Lee. So rates of mental health outcomes vary widely across the studies, and so if you think about that, what might explain some of that variation? Are we talking about sort of difference in measures? Is it difference in populations? So how do you think about that variation?
Yeah, this was certainly one of our most challenging areas when we think about the wide variety of rates. And looking back in the studies, there was such a variety of populations, of metrics, of study settings, of how they obtained the metrics that they studied, of the methods. So just for example, we have, US systems, we have UK, all the different EMS systems that we studied from all over the world. And then within that, some of these are urban, some are rural, some are flight. And then even within that, we have different types of systems. So some are only answering 911 calls or emergency calls. Some are set just within the fire service. Some are run by private hospitals. Some are run by, by private services that are functioning just within themselves. And this seems like, well, they're all EMS clinicians. Shouldn't we be able to judge them? But, being in the field, I was a paramedic before, kind of back in the day. And, thinking about my own experiences in EMS, thinking about my communications with current EMS clinicians and medical directors, there's such a wide variety of how the experience of the EMS clinician inside of different types of departments. And so my initial thought, and we weren't able to do this with this study, but to look at, are there certain types of services that have improved systems, or is there something about the types of services that the rates of depression or burnout are better, right? Also, in some countries, the type of licensure and education are even different amongst EMS clinicians, right? And so everyone has a bachelor's or a master's to be a paramedic, and some it's an associate degree. So there's just such a large variety. And then when you go back and you even look at the metrics, so take burnout for example, that was one I spent a lot of time on. The number of different metrics just for evaluating burnout was so massive that it made teasing some of these answers out very challenging. And so even when the study authors would use maybe a MALAC burnout inventory score, right? It turned out that you know, over the course of 20 years, there were so many different versions of the M.B.I. or the MALAC burnout inventory that it almost made comparisons between those studies impossible. My other study authors are welcome to chime in, Eric or Ian, but we really just found it very challenging between such the wide variety of populations and metrics and settings that we were studying.
Yeah, thank you for that. I mean, it really brings like to the fore, I think, some points that were raised early on in our conversation today around sort of just how messy it is, right? To really try to look at some of these questions and figure out how you tease apart all of that complexity so what questions can I even ask? And when I get the answer, how helpful is that from taking a step back and thinking about how you now apply this, right, to like the entire system, or think about it from like the patient perspective, which was a point that I think Samruddhi raised as well, right? It's incredibly challenging. And I think that's something that we see across the reviews and the reports. So I'm going to ask a question of Hassan and sort of say to you, and this was something that Craig raised as well around those 11 categories. So want to get a little bit more information from you about what guided the selection of those 11 categories and what kind of trade-offs and limitations were you thinking about when trying to capture the whole picture of documentation burden?
So first, it's important to recognize that these categories are, they do overlap a little bit. So the boundaries between them could be ambiguous to some extent. And I think different categorizations are also possible. So it's not like this is the end of the story or the ultimate categorization. So what guided the work? First of all, we were looking at distinct concepts. So for example, the work outside of work seems like a very distinct concept, or what sometimes people call it pajama time, where you're working really outside of the office. So that is very unique and different from just time, which is different probably from usability. So we were looking for different or unique concepts. That's one part of it. The other thing that guided the selection of these different types of measures is we were also thinking about intervention. So, for example, we could have lumped the measures like the third and fourth and fifth measures. We could have lumped them under time, but we thought that splitting them to in-basket time, clinical review time, actual documentation time, that splitting them may help future interventions because the interventions could be different. So if an organization wants to intervene to reduce documentation burden and they want to target in-basket time, they will have different interventions and approaches than something that would address, for example, the actual note entry time or the note creation time. So yeah, I would say these are the two main factors: is uniqueness in terms of the concept, and also possible different target for intervention.
Great, that's really helpful because it sort of gets at one, right? Like how can you tease apart what is distinct, and two, like where is there an opportunity for action? And so that's really helpful. It's also I appreciate the points around, you know, there's more than one way to do this, and it's really hard to do it in a way where everything is going to end up being like mutually exclusive. And so those were great points to highlight. I want to come to Mike and sort of surface a few things out of that. So when you look at the sort of the mixed effects that you saw across medical error, morbidity, and mortality outcomes, what were the factors that you think really contributed to those findings?
Yeah, I think, echo a lot of the past comments are applicable here, the variety of outcomes, many like poor study design issues and measurement issues. But I really think what's unique about these types of interventions is really, I think I like Craig's framing of it, is a schedule intervention is not just a scheduling intervention, even if that's what you try to isolate it to. It changes the delivery care model, it changes how teams come together, it changes the nature of work you're doing during that time. So I'm, especially in an inpatient setting, I'm now spending more of my time getting up to speed and getting to know these patients versus, so that makes it more effortful. So there's a lot of, I think, that piece to it. And then I think there's a lot of unmeasured influences on fatigue. It's not just how much time you're there, it's how stressful that time was, and many other things. It's what happened to you before you got there. There's lots of things that aren't measured in these studies that are clearly going to be impactful, and the interventions themselves are more than just an individual schedule thing. They really do change interaction patterns with folks.
That's like one of my, it's like my favorite / least favorite thing about, you know, doing interventions in the practice setting is like, you fiddle with, you know, one thing over here, and then you just get to find out like
Right.
all the cascading effects that come from it, right?
Absolutely.
Yeah, that complexity is both, I think, like invigorating and incredibly frustrating. All right. Well, thank you very much again to our report authors. I want to kind of pivot us over to our discussants for a little bit of conversation. So this is an opportunity for us to talk a little bit at a higher level around kind of implications for policy, for practice, you know, for health systems and for equity. So I'm going to start by asking a question around that looks at the second report. And so want to sort of toss this out to folks. Given the evidence that documentation burden contributes to stress and burnout, something that I think is not a huge surprise. So, and this is especially among physicians, how should health systems and policymakers respond to this? And when we think about who should take the lead, right? Like which organizations, you know, agencies, professional societies, et cetera, should really be taking the lead in validating and standardizing burden measures, which we see as a challenge for us. So that was kind of a lot, but who wants to jump in on that? Take volunteers here. And this is for Jade, Samruddhi, and Craig.
Yeah, Elizabeth, I'm happy to jump in first, and I repeat a little bit of what I had said previous. You know, this feels really ripe, of course, for federal intervention to lead in these efforts, and really is something that through the National Action Alliance there has been some focus. So for those of you who may not know, the National Action Alliance for Patient and Workforce Safety, we do have a government-wide working group, and so we work on different issues that are that are directly applicable to patient and workforce safety, and so I'll just share as part of that, you know, CMS has already been a really wonderful leader in burden reduction area. Several years ago, during the first Trump administration, they led the meaningful measures work, and so they were, you know, went through the process of reducing the amount of measures that they would require. I of course no longer work for CMS and are at AHRQ, but I do believe that similar work is underway more from a regulatory standpoint, and just last week was made aware that CMS, their OBRI office, which I forget exactly what the acronym stands for, is hosting a burden reduction symposium next month. So I think that there is great work that's occurring here. We have a lot more work to do. It is exciting to me to think about some, I think, robust and rapid gains that could be made through working with vendors, and yeah. So I'll leave that there. Thank you.
Great. Yeah, thank you. Are there other responses from our other discussants?
I think I can weigh in maybe briefly. So one thing, that for documentation burden, I have noticed, and, that didn't really emerge from this report, but I have been privileged to experience healthcare services in Chapel Hill, Durham, North Carolina for over 30 years. And I say that because just from a patient perspective, from a family member perspective, and a researcher perspective, one of the changes I've seen is 30 years ago, at least, that's how far I can go back. I experienced, when I saw a patient or when a family member saw a patient, it was the doctor and the patient, or a nurse and the patient, and you can fill in the gaps. Now what I'm seeing is, instead of a dyad, it's actually a triad, or in some cases it's, two additional members. One is an AI scribe device and a computer, and the provider and the patient. And if the patient had a person with them, then that person. So the reason I'm mentioning this is because one of the observations I have is, it's almost the documentation burden, why we do what we do, what we document, has changed. The dyad, at least I'm not experiencing anymore, and this is not a personal comment on any of the excellent providers I have the privilege to be served by, or my family members have the privilege to be served by, but the amount of time the provider actually makes eye contact with the person has changed, from at least my experience. And again, 3 decades I can look back, and the key factor I attribute to is, just as I said, it's no longer a dyad. It's either a triad or it's one more device. So 4, present, and providers focus more time, more eye contact, more of the talent documenting. And I would suggest we need to ask ourselves the question, why are we documenting? And as I understand, most of the documentation, at least I see providers do, is tied to being able to have enough information to have the correct, or hopefully the highest level of reimbursement. A lot of times I'm starting to see information errors, and I'll just mention, one quick error. I had a family member in a hospital for a good 20 days. It took 19 days for me to identify that somewhere somebody had documented that this family member does not speak English. And so for 19 days, the providers would come and go, document a lot of information, some of the same information, but not once, when I encouraged them to talk to the family member, they would interact. And it was on the 19th day is when I found out that because somebody somewhere had documented that the patient does not speak, not just does not speak English, which would also be erroneous, but does not speak. So I'm mentioning this because kind of like, why are we documenting, and the accuracy of documentation and the time that's spent to document is essentially to document for reimbursement purposes, as far as I see. The rest of the documentation, who is reviewing it, how much it's being reviewed, how much it's being used for patient care, I mean, that for me is becoming an open question as I navigate the healthcare system, as I think about this information as a health services researcher, just begs the question, why are we documenting? And can we identify some of the items some of the information that doesn't even get used by anybody, so that the burden even on the patient, on the caregiver, also gets reduced. Another, I call it an opportunity to look at and say, is there burden that we can just, what I call, eliminate, because the items are not being used, the information is not being looked by anybody. Let's just get rid
Yeah.
of some of
So how can, so how health systems should respond, right, is sort of a matter of thinking about, should that burden actually be there in the first place? Why are we doing it? What is it for? So those are excellent points. I don't know, Craig, do you have any additional comments you want to share?
Well, maybe one or two. One is I really do think this is a big opportunity for AHRQ to leverage AI and newer technologies to create some measure of burden of use of EHRs, which could then be used by groups like CMS, around reimbursement and encourage vendors to really work on usability, or used by groups like Leapfrog to capture in their hospital safety grade. Currently, they capture CPOE, barcode administration. You could imagine some measure of EHR usability for staff, given its potential impact on patient safety. So that's my biggest takeaway.
Great, thank you so much. I'm going to see if I can squeeze one more question in here. Although I will say, well, I'm gonna scrap what I was gonna do, because we do have a question that came through the chat, and it's my prerogative to prioritize that. So we have another comment from Donald Leiter, who said documentation errors are rife as rushed providers try to keep up with their schedules. AI scribes are proposed to be a potential solution. Will the healthcare system be able to support this feature financially as well as operationally? So want to just see who, and I think we can include also our report authors as well, but who might want to jump in and respond to that?
I can say something. So AI is probably like the most obvious solution for documentation burden, and there are a lot of AI applications right now that some are proprietary by different vendors and some are from the EHR vendors, and these are already being used. So this field has moved very quickly beyond beyond what we have imagined in the past. So right now there are AI scribes used all over the place. And then the other point is that there was, the comment that was mentioned about what are we documenting. This is also very important because, and this actually came through our interviews with key informants, that it's not like just we want to continue to document the same thing and find someone else to document them to reduce the burden. No, we need to look at what we actually are documenting, because most of this is done for either billing or for defensive medicine, for worry about legal malpractice and so forth. So we need to review, what do we really need to document? That's key in any intervention.
Yeah, I feel like that came through loud and clear, in all of the comments and discussion here today, right? There's a very pointed, like, what are we doing sort of vibe, right? And I think it's valid, right? I mean, I just went to the doctor actually last week, and that was my lived experience. So, and that's no like shame or critique, right, to my doctor. I feel like that is what we are living right now. So it is a very real challenge, and it's interfering with the doctor-patient relationship. And it's unclear how much it's contributing to actually better quality of care. So these are excellent points. I see that we are coming up on our time together. So I am going to turn it over to Lucy to wrap us up.
Great, thank you, Elizabeth. Excellent discussion. I want to thank our authors, Lee, Hassan, and Mike. Thank you so much for sharing your report work with us. I want to also thank our discussants. So Jade, Craig, and Samruddhi, thank you for joining us with your excellent observations. Elizabeth, thank you for a great job facilitating. Sorry, I was not on the mend today. and to Taylor Dunlap for executing the session so well. The CME information will be in the chat for those of you who are interested in receiving CME for participation in this event. And we'll post this session as soon as possible, and it'll be distributed to everybody who signed up for the event. Thank you very much, everybody. We look forward to having you join us at another Grand Rounds.
Thanks, everyone.
Thank you.
Thank you. Thank you for including me. Great work, everyone.